Just give me 1 minute. So good evening, doctors and all the participants. I come on behalf of Shield Healthcare, welcoming you all in today's session with Dr. Pranavika Mahanto, Madam Goswami, Madam, on management of urinary tract infection. Moving into the session, I'm honored to introduce Madam. Madam is the Assistant Professor, OG JMCH, and Madam is the Deputy Superintendent, JMCH Secretary, Jorhat Obstetrics and Gynae Society, and the Joint Secretary Doctors Club Jorhat, Faculty of MCI Regional Center for Faculty Development, and Jorhat Medical College and Hospital, Assam. And in terms of interest, she has keen interest in endoscopy and infertility medical education. So with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, once again for your valuable time in our platform Shield Connect, and over to you for further proceedings. Thank you very much.
Hello.
Please. Hello. Yes, madam. You can start.
Yeah. So good evening, everyone. Today I'll be talking about the management of urinary tract infection. Please, next slide, please. So what is UTI? UTI is an infection in any part of your urinary system, including kidneys, ureter, bladder, and the urethra. Most infections involve the lower urinary tract of the bladder and the urethra especially. Next, please. So if we go through the epidemiology, asymptomatic bacteria is very common, especially in ladies. So it is around 10 to 13%. Acute cystitis in 1 in 4%, acute pyelonephritis in 0.5 to 2%. Though incidence of bacteria in pregnant women is only slightly higher than the non-pregnant women, the chances of progression to pyelonephritis is significantly higher, that is about 40%. The rate of recurrence has not been calculated by any randomized control trial or measure study. So this has been taken from the Cochrane database. Next, please. So this is a study which show prevalence of urinary tract infection and current scenario of antibiotic susceptibility. So these, in this, they have concluded that as the drug resistance among bacterial pathogens is very much with time to time regular surveillance and monitoring is very necessary for giving updated information to physicians for most effective empirical treatment of urinary tract infection. This is a very informative study. Next, please. So if we see the incidence that I have already talked about, it is the second most common infection following that of respiratory tract infection. 40% of all women will suffer from at least once in a lifetime, and 1 in 5 women between the age of 20 to 65 suffer from a major attack per year. Approximately 30% of the pregnant women suffer from urinary tract infection. So it's a very high incidence of infection in a pregnant lady. Next, please. So what are the causes? So it may be through different routes actually. So we can, first one, I should explain that women being mostly susceptible because of their anatomical disadvantage. Their urethra is short, so ascending infection is very high, and the urethra is also near to the anus. So it is easily the infection ascends up. So next is birth control may introduce harmful bacteria during their the process of sexual intercourse, may introduce harmful bacteria from GI tract, may allow bacteria to grow, then allows bacteria to flourish. Because of suppressed immune system, there can be like bacterial flourishing growth of the bacteria, and this because of the catheters or any catheters, there may be bacteria may be allowed to grow inside, Then in pregnancy, there is altered immunity, which causes defective flushing, because in pregnancy there is retention of urine, especially because of poor muscle tone of the urinary bladder. So there is retention of urine, and there is more like stagnation of that urine in the urinary bladder, which causes the defective flushing out. Then postmenopausal women, there is altered pH and defect in the immune system. So in the postmenopausal women, where we get less of like the good bacteria are less and the bad bacteria started growing, and this causes the root that makes them immune, like that makes them more prone to urinary tract infection. Next slide, please. So this, we can see uncomplicated UTI, complicated UTI. The risk factors are indwelling catheters, immune suppression that we have already talked about, urinary tract abnormalities, antibiotic exposure. Female as a gender is more exposed, older age and younger age. So most common is the Enterococcus, E. coli, Klebsiella, Streptococcus. These are the organisms which are mostly seen. Next slide, please. So urinary tract host defense, first urine itself, it's acidic pH, intolerable by some pathogens, high urine osmolarity, urinary inhabitants of bacterial adherents, competitive inhibitors of attachment of uroepithelial cells, mechanical flushing of urine flow. So this prevents urinary tract infection. This acts as a host defense mechanism. Then mucosal immunity, urethral secretion of cytokines and chemokines. This helps in increase immunity of the host. Then mucopolysaccharides lining, that increases difficulty of the bacteria for penetration. Then mucosal IgA immunoglobulins. So in men, prostatic secretion contains bactericidal zinc and urethra is longer. So this is why we do not get so much of urinary tract infection in the male, like unlike that of in women. Next slide, please. Yes, pathogenesis, we can see urinary tract infection. First, it starts in the urethra. There is colonization of the pathogen, and then it ascends up through the periurethral area, through the urethra upwards towards the bladder. In the uroepithelium, there is penetration inside the uroepithelium. That fimbria allows the bladder epithelial cell attachment and penetration. Following this penetration, bacteria continue to replicate and may form a biofilm. When it forms the biofilm, it cannot be acted upon by the host defense mechanism. Then it ascends up. There is this ureter. It will ascend through the urethra. Once sufficient bacterial colonization occur, it may ascend towards the urethra, towards the kidney, and fimbria may aid in the accession process. Bacterial toxins may also play a role in inhibiting peristalsis. It inhibits the peristalsis, that reduces the flow of urine. There will be stagnation of urine, and when there is more of urine, there will be more of culture media, and this will grow. Flourishing growth will be there. Infection of then it will ascend to the kidneys, and this will cause infection in the renal parenchyma, that will cause an inflammatory response, which is called as pyelonephritis. While infection of the renal parenchyma is usually the result of bacterial ascension, it can also occur from hematologic spread. It can come from here also, from the blood also, but this is one of the most important cause of pyelonephritis. Then this will cause acute kidney injury. If the inflammation cascade cannot be broken down, the tubular obstruction will be there, damage to the intestine. There will be damage of the renal parenchyma, and that will lead to interstitial nephritis, which will cause acute kidney injury and acute tubular necrosis actually. So this is how urinary tract infection occurs in human being. Next slide, please. Okay, there are certain risk factors. It can be iatrogenic, as we have already talked that if we are putting an indwelling catheter, we are using antibiotics right, left. It can cause, if we are using spermicidal gels, this may cause this may kill the normal good bacteria and can help in growth of the abnormal bacteria. Then behavioral process, if we have certain patient has certain voiding dysfunction, if frequent or recent sexual intercourse. And this is actually advised that after sexual intercourse, before and after sexual intercourse, one should void urine so that this infection cannot ascend up. Then anatomical and physiological, that vesico-urethral reflux, this usually occurs who have a posterior urethral valve or some issues, that type of issue. In those patients, we used to get recurrent infection. Then female sex, those who have a shorter urethra will have more chance of infection. Then in pregnancy, yes, we have a lot of urinary tract infection because there is less of immunity, and also there is retention of urine. So this may cause. Then genetic, there are certain familial tendency, also susceptibility to uroepithelial cells and vaginal mucous properties. So this can be risk factors for urinary tract infection. Next, please. So symptoms, usually we get pain or burning or urination, fever, chills, malaise, hematuria, irritation of the bladder, urethral mucosal resulting in tinged urine, cystitis. If there is cystitis, then frequency and urgency, suprapubic pain, foul smelling urine. Pyelonephritis, we get infection, lower UTI flank pain we get. But unfortunately in pregnancy, we do not get such typical presentation of urinary tract infection. We may get a back pain in pregnancy, or she may have some discomfort in the lower abdomen, but typical dysuria or malaise, fever, we don't see frequently in pregnancy. Next. So common causes, this Escherichia coli, it is involved in 80% of the cases. This, we should remember that this is one pathogen which is already there in our bowels. So this is very close, our anus is very close near to the urethra. So this comes to be the #1 cause of urinary tract infection. Then we have Enterococcus, Klebsiella, Enterobacter. Next, please. So this is urinary tract natural defense of the urinary tract. So if we see the natural defense, urine becomes acidic during urinary tract infection, which kills most of the bacteria. D-MANNOSE in the urinary tract does not allow bacteria to stick to the uroepithelial cells. This is also there in the urinary tract. Then bacteria moving upwards are regularly flushed through urination. These are the 3 main defense mechanisms that we have to prevent from urinary tract infection. Next. So most common form of recurrent urinary tract, recurrent and persistent asymptomatic bacteriuria. This is mostly seen in the pregnancy. However, it may also present as acute cystitis or pyelonephritis. Next, please. If we are primary symptom asymptomatic bacteria is not treated, then that can lead to acute pyelonephritis. Next slide, please. So asymptomatic bacteria, Infection Disease Society of America, they have said that significant bacteria, if one's urine is cultured, monoculture in the quality of more than 1 lakh colony forming units are there per ml in 2 consecutive midstream clean catch urine specimen, then we can say that she has this significant bacteria that may cause problem to her. So asymptomatic also there can be, but this is significant. We should treat those cases. Next, please. About ACUTE and this American Academy of Pediatrics, they have given a recommendation that screening of bacteria at first prenatal visit or at 12 weeks, whichever is earlier, is mandatory, because pregnancy, as I have already told, that there are very less symptoms. We cannot make out the frequency if someone is having frequency of urination, whether it is because of her pregnancy or because of urinary tract infection. This cannot be actually determined. So it is very much mandatory, or screening is recommended by ACUTE, that we should go for it in the first antenatal visit. Next, please. Acute cystitis, approximately 1% of all pregnant women, we can see cystitis, acute cystitis, almost always results from an ascending infection. If asymptomatic bacteria, which was a significant one, is not treated properly, then it can lead to acute cystitis. Next, please. Acute cystitis, you will have dysuria, frequency, urgency, suprapubic pain, in the absence of systemic illness, hematuria, lower urinary tract symptoms with pyroluria accompanied with a sterile urine culture, may be from the urethritis caused by chlamydia trachomatis. So this can be an association. Next, please. Pyelonephritis, it is the most common serious medical complication of pregnancy, which was leading cause of septic shock during pregnancy. Pyelonephritis is unrelated and right-sided. Mostly it is right-sided in more than half of the cases, and it is bilateral in a fourth of the cases. Next, please. In pyelonephritis, we will see abrupt onset of fever, shaking chills, aching pain in one or both of the lumbar regions, anorexia, nausea and vomiting, tenderness elicited at a costovertebral angle. So if someone is, we get costovertebral angle tender, she is in a serious state of urinary tract infection. Next, please. E. coli again is the #1 cause of acute pyelonephritis. Next, please. Klebsiella, we have Enterobacter. Acute pyelonephritis diagnosis, gold standard is the renal biopsy, but this is an impractical in clinical practice. A combination of symptoms, full blood count, inflammatory markers, renal function test, blood culture, renal urine culture sensitivity test are used. So this is mostly, actually we do it clinically rather than going for a renal biopsy in pregnancy. So this can be easily tackled with a thorough clinical examination. Next, please. Yeah, it's a medical complication, and endotoxin-induced alveolar injuries are manifested in 10% of the women and may result in frank pulmonary edema. It may be severe enough to cause ARDS. Yes, we get patient with this because once she goes into the state of acute pyelonephritis, she will have all the symptoms of septicemia. Endotoxin can also cause hemolysis and also causes anemia. Bacteremia is demonstrated in 15 to 20% of the cases, and transient renal dysfunction. This is a very common finding which frequently seen in patients with septicemia. We get transient renal dysfunction and again they recover. Next. Obstetric complication, yes, since there is an infection, this will induce labor and that will cause preterm labor, preeclampsia, chorioamnionitis, postpartum endometritis. Next, please. So if it is a preterm one, if fetal complication, if it is a preterm one, it will have a low birth weight also. Prematurity is another factor, developmental delay, mental retardation, perinatal mortality. This will lead to increased perinatal mortality. Next. Differential diagnosis can be chorioamnionitis. Here, what we do is we take a high vaginal swab for culture and we check whether it is the organism is in the urine or in the vaginal canal. Then appendicitis. Current, yeah, I can go to the next slide. Yeah, current treatment. We have 4 modalities of treatment. We use alkalizer to relieve the burning micturition, which can be annoying at times. Then there can be spasmodic pain. It can be tackled with flavospas or that's type of antispasmodic drugs, antibiotics to eradicate the bacteria, then cranberries to flush out the bacteria. Next. So asymptomatic bacteria, this actually will depend on the result of the urine culture report. We usually prefer giving antibiotic after we see the culture report. So this is entirely like will be her sensitivity report. So single dose treatment via ampicillin, cephalosporin. Mostly we use nitrofurantoin. Then for 5 days or 7 days, usually we do give this treatment. But yes, near time, we do not prefer giving nitrofurantoin. Next, please. All pregnant women with asymptomatic bacteria should have periodic screening after therapy, since as many as 1/3 of them experiences a recurrent infection. So that should be repeated. Follow-up culture should be obtained 1 to 2 weeks after treatment and then repeated once a month. Next, please. Nitrofurantoin 50 to 100 milligram bedtime until the end of pregnancy. Postpartum urological evaluation may be necessary in a patient with recurrent infection because they are more likely to have structural abnormality of the renal system. If someone is having recurrent infection, then we should evaluate. Next, sometimes there can be stone in the kidney also or urethra. Acute cystitis, increasing oral fluid intake is frequently advocated as a first-line treatment for pregnant women with features of symptomatic urinary tract infection. Nitrofurantoin for 7 days, urine alkalizing agent, cranberry juices. Next, please. So in acute pyelonephritis, we should hospitalize her, obtain urine and blood culture, evaluate hemogram. So we should go for this urine and blood culture because we want to know that where from that infection has come, whether it is ascending or it is from the system blood stem. Evaluate hemogram, serum creatinine and electrolytes. Monitor vital signs frequently, including urinary output, considering indwelling catheter. Establish urine output more than or equal to 50 ml per hour with intravenous crystalloid solution. Next, please. Acute pyelonephritis, we administer intravenous antimicrobial therapy. Then we obtain chest radiograph if there is a dyspnea or tachypnea, because fluid effusion is also very common because kidney is not functioning properly. So there will be fluid retention. Then we should repeat the hematological investigation reports and chemistry slides, studies in 48 hours. Change to oral antimicrobials when afebrile or discharge when afebrile for 24 hours. We should consider for antimicrobial therapy for another 7 to 10 days oral therapy. Then repeat urine culture at 1 to 2 weeks after antimicrobial therapy is completed. Next, please. So non-steroidal inflammatory drugs can be added for symptomatic relief if they are having pain. Thromboprophylaxis should be used if the woman has reduced morbidity or a period of bed rest is there. The use of graduated compression stockings or low molecular weight heparin has a role in this. Next, please. Antimicrobial of choice. Again, this is also will depend on the urine culture report actually. So empirically, if one wants to start, then ceftriaxone, cefepime, this can be used. Severe acute piperacillin tazobactam can be used. Okay. Next, please. So these are certain drugs which are categorized as antibiotics according to the safety level of in pregnancy. So category B drugs we use, C and D we should not be using. So ampicillin, cephalosporin, piperacillin, dapta, azithromycin, erythromycin, clindamycin, nitrofurantoin, vancomycin, and metronidazole. These can be used safely during pregnancy, but others we should be cautious using those drugs. Next, please. So major infection in male. Male, should I be saying? Next, please. Yes. Let's. Okay. In male, urethritis, prostatitis, from that major infection can come to the urinary tract infection. Next. Epididymis, orchitis. Most of the patients are asymptomatic in male. Chances of high rate of chronic infection is there. Detection of pathogen increased while WBC count. This can be seen on blood picture. Next, please. So if someone has infection, we can have one can have chronic epididymis, chronic prostatitis. They will have this scrotal pain, tenderness on the testes or epididymis. Excuse me. Then pelvic pain can be there. So first void post prostatic message, then again take 2 glass test is there. Then this is usually done to see leukocytes in the urine and uropathogens. Then if he is STI positive, then antimicrobial therapy for both of them. And if this comes positive, we will see the sensitivity report and give the antibiotic. Next, please. Commonly used antibiotics, these are ampicillin, ceftriaxone, levofloxacin, fosfomycin, and cephalosporin. Plant nutraceuticals, they have many of the nutraceuticals or their activities in antioxidant activities actually. So these are nutraceuticals are used in UTI. Next. Powerful this arsolic acid, the powerful anti-inflammatory and analgesic action is there. They inhibit the pro-inflammatory cytokines, tumor necrotic factor A and the prostaglandin E2. Anti-inflammatory effect comparable to indomethacin. It has a powerful antioxidant effect, prevent tissue damage and inflammation due to oxidative stress. Anti-inflammatory effect has been actually evident. The evidence says that it is very much effective in urinary tract infection. Next. Effect of cranberry extract, arsolic acid derivatives. This has been actually established in many systemic reviews also, that these are doing excellent work in urinary tract infection. Next, please. Potassium, this citrate pharmaceuticals, potassium magnesium citrate, this is mostly used, produces high concentration of bicarbonates in the urine that will alkalize the urine, neutralize the acidic environment of the urine, and burning micturition will be relieved promptly. Next, please. D-MANNOSE in bacterial detachment. D-MANNOSE is similar in structure with that of that binds to the site of the urothial glycoprotein receptor, such as uroplankin. That saturation of this receptors adhesin, and it will prevent the bacteria from binding to the urothial glycoprotein receptor if the present in the sufficient concentration in urine. So there will not be any receptor to bind for the bacteria. Pro-anthocyanin, it's an active ingredient of cranberry extract. 3 types of these pro-anthocyanidins are there, A, B, and B2. Next, please. So fructose, basically how it works, fructose inhibits the binding of type 1 fimbria to the uroplankin receptors. Pro-anthocyanidin prevents binding of this P fimbria to this glycoprolipid receptors. Hence, there will be a saturation of the receptors. Next, please. Ideal treatment we can give for pain arsolic acid, which is a powerful anti-inflammatory drug. Then burning micturition, we can give potassium magnesium citrate, which will neutralize the acidic pH and will alkalinize, and this will reduce the burning micturition. And for recurrent, we can use cranberry extract, that is an active ingredient of A and exert anti-adherent properties. Then D-MANNOSE, it exerts an anti-adherent property. Next, please. So now to sum up, urinary tract infection is an infection in any part of your urinary system. Females are more prone to develop urinary tract infection than the male counterpart. 40% of all women will suffer at least one urinary tract infection at some point of their life. Though incidence of bacteriuria in pregnant women is slightly higher than non-pregnant women, the chances of progression to pyelonephritis is significantly higher, that is around 40%. High chances of pregnancy complications are there. First-line therapy includes antibiotics. Nutraceuticals provide relief from pain, burning sensation, and flush out the bacteria. And it also, we can buy time. By the time we get the report of urine culture, we can use this nutraceutical to by that time, so that she is comfortable till her culture report comes, and we give only one antibiotic. Thank you.
Thank you very much. Just give me 1 minute time, ma'am, to check if any question is there. Ma'am, the first question is, does this antibiotic is needed in all the cases of UTI, or is there any specific condition where we can use this antibiotic?
Yes. So antibiotic actually is recurrent for eradication of the disease, but for symptomatic relief, we do not need antibiotic. So for symptomatic relief, what type of antibiotic to be given? We should actually go for a culture sensitivity test of the urine, and then we can give the specific antibiotic which is required. And by that time, we can have put her on those alkalizers or some others so that she gets relief of that symptoms, because it will take 3 days time for a culture report to come. So antibiotic we have to give, antibiotic. Yeah.
And ma'am, is there any difference in the treatment protocol in terms of UTI in pregnancy?
Yes, definitely. Pregnancy, we can use only those cases, those category of drugs which are safe. So category B drugs only we can give. So so culture sensitivity in pregnancy is really required, because if we are giving a non-sensitive drug and she is also taking, she will be exposed to that antibiotic also. So we have to be very much cautious in giving antibiotic in the right dose and right time actually. So in non-pregnant ladies, we can just go for an empirical broad spectrum antibiotic. There's no harm giving that, and she will be relieved. But for pregnancy, yes, and once you start an antibiotic, we cannot, like if you stop it in between, like one day you have given and the culture report has come out to be ineffective, then this will have a resistance effect to the mother also and to the baby also in utero, because we are exposing the baby also to a smaller amount of antibiotic. So yes, for pregnancy we have to be extra careful what antibiotic we need to give.
Thank you very much, madam. And madam, what is your opinion on this ursolic acid? And just to share with you that many research and evidence is also there that it has significant anti-inflammatory action.
I
So
can't
what
hear
is your
you.
practical observation on that?
I can't hear you properly.
Sorry,
Please repeat your question.
can you
Hello?
hear me, ma'am? Is my voice clear now?
Your voice is
Yes,
breaking actually.
ma'am.
Ma'am,
Can you hear me?
his question is that what is your usage experience and opinion about ursolic acid when it comes to urinary tract infections?
Yeah, we are using this drug, and that's what I like. Initially, when a patient comes with urinary tract infection, like first visit, this is very difficult in pregnancy to diagnose, because pregnancy we don't get all those symptoms that is required. But those non-pregnant ladies who come with the features of, especially those who are like just married, they used to have this cystitis problem. Those cases it's very effective, and we start with that and they immediately get relieved also sometimes. So this, we are using this drug.
Thank you very much, madam. And another thing, ma'am, less amount of water intake leads to UTI. Do you agree on that? What is your opinion?
Yeah, that is the number one actually cause. You can say that the flushing effect of urine, that is what is the natural defense of urinary tract. So urinary tract infection people doesn't get just like that, because there is that flushing out of the pathogen by the natural mechanism. So if you are not taking water properly, the urine, there is less amount of urine, and urine is always a good culture media. So if it is there is stagnation of urine, there is no proper flow of the urine, and there is jam of the urine, so that will cause, definitely that will increase the chance of urinary tract infection. And if you are having an urinary tract infection, it will aggravate that and it will lead to acute pyelonephritis. So to increase the urine flush activity, we need to have plenty of water. That will automatically, if someone is starting the urinary tract infection in some, they start taking plenty of water, that will flush out the smaller amount of bacteria, and this will not increase the intensity of infection, and this will subside of its own, just taking water. Yes.
Thank you very much, madam. And another thing is, what is your practical observation? And does this UTI is somehow related to the socioeconomic condition of the patients or anything else?
Socioeconomic condition you cannot say, because one's personal hygiene, someone may be socioeconomically
Hygiene is it can be
yeah,
test.
someone may be of lower class, but they may have a good sense of hygiene. So you cannot just say that their socioeconomic background is bad, so they will be in an inappropriate environment. That is not the thing for urinary tract infection, because one may harm, that is her immunity or her food habit, that may be different, like that of I can say that the immunity may be different for two different class of people, but hygiene is something from like something different. Hygiene can be like if someone is taking water, cleaning up their this is not going to cost high for anyone. So that is a different thing for both the both the group of people. So I cannot just comment that lower economic people will be in less hygiene condition, but or increased chance of yeah, that is different. Actually, that is different.
Rather, you can say ICT is the main concern for this.
Yeah.
So thank you very much, madam, for this nice discussion. And I could not find any other question in our dashboard. If we get any, we can obviously forward it to you. And thank you very much, madam, once again for your valuable time with us. And in future also, we look forward for some valuable session.
Okay.
So thank you very much, madam.
Okay, welcome.
Thank you.
Thank you, Suman.